The muscles of respiration consist of primary muscles that move the pleural lining that connects the lungs to the structures outside of the lungs. This includes the diaphragm muscle and the intercostal muscles between the ribs. There are a variety of accessory muscles that help support the process of respiration in the neck and in the thorax and in the abdomen. These muscles move the diaphragm and the rib cage, and with the pleural linkage between the lungs and the diaphragm and the rib cage, action by these muscles will influence the size of the lungs, which influences the pressure of the air inside the lungs, which causes airflow. An important component of the connection from these muscular movements to changes in lung size is the pleural linkage. The parietal pleura lines the inside of the interior rib cage, the superior part of the diaphragm. The visceral pleura is a wrapping that surrounds the lungs. The lungs expand and contract with the diaphragm and the rib cage due to a linking between these two pleura, which is a negative pressure between the two pleura created by a liquid layer in between them. That intrapleural pressure is always stronger than the pressure within the lungs, otherwise the lungs would collapse. The primary muscles of respiration are the ones that play a direct role in moving the structures around the lungs and causing changes in lung size. The diaphragm is one such muscle that is in an inverted upside-down bowl shape at the base of the lungs. Fibers of the diaphragm course from around the edges of the lower rib cage toward the center of the diaphragm and have an attachment to a large tendon called the central tendon. Contraction of these muscle fibers pulls that central tendon inferiorly toward the surrounding lower rib cage, and that effectively flattens out that bowl shape, expanding the lungs inferiorly then because of the pleural linkage. The other major muscles for changing the space around the lungs are muscles in between the ribs. The external intercostal muscles course downward and forward from one rib to the next. As a result, contraction pulls the ribs upward and toward the vertebrae, which stretches the costal cartilage and expands the rib cage laterally and anteriorly. The internal intercostals run perpendicular to the external intercostals. They course downward and backward. As a result, when they contract, they help pull the rib cage back toward the sternum and shorten the costal cartilage, decrease the size of the rib cage space. These primary muscles are supported by a variety of accessory muscles. In the neck, we have the sternocleidomastoid that helps hold up the clavicle and the sternum, which are the superior and anterior parts of the rib cage, by a connection to the mastoid process of the skull. The scalene muscles, which come from the cervical vertebrae, connect to ribs 1 and 2 and help stabilize the superior part of the rib cage. In the thorax, we have a variety of inspiratory muscles that help expand the rib cage, including the costal levators. If you remember them from anatomy, there are both longus and brevis versions that pull upward from one rib to the next lower rib, or the lower rib 2 ribs down. The pectoralis major, which is a chest muscle that connects from the anterior part of the rib cage into the shoulder. The serratus anterior, which is a set of muscles that wrap around the sides of the rib cage from the scapula. The serratus posterior superior, which comes from some of the superior vertebrae, including the last cervical vertebrae and the first 3 thoracic vertebrae, course downward and laterally into the ribs. And the subclavius, which is a muscle that runs from the clavicle into the first rib. These muscles can act to expand the rib cage either directly with extreme contraction or by stabilizing upper ribs to allow more movement of the lower ribs. On the expiratory side, we have thoracic muscles that are a little bit lower down in the rib cage. The pectoralis minor, which is a smaller muscle underneath the pectoralis major that connects to a little bit lower part of the shoulder and the armpit area. The serratus posterior inferior, which connects from the lower vertebrae up into the lower ribs. The subcostal muscles, which are similar to the internal intercostals, running from a rib to 2 or 3 ribs below in the inferior part of the rib cage. The transverse thoracic muscle runs from the inner side of the sternum and courses out to the ribs and works directly against expansion of the rib cage by stretching the costal cartilages. Abdominal muscles can also help with expiration indirectly by compressing the material in the abdominal cavity. They also help anchor the lower rib cage and therefore work in opposition to the diaphragm muscle. The abdominal muscles include the rectus abdominis, which courses up and down, the external oblique abdominis, which courses from the upper sides of the abdominal cavity and the lower edge of the rib cage toward the center of the abdomen, which has a central tendon as well. The internal oblique abdominis, which courses diagonally from the pelvis up into the central tendon, and the transverse abdominis, which runs in the transverse plane from left to right from the edges of the rib cage, and also a tendon that runs between the pelvis and the lower rib cage, again to the tendon that's at the center of the abdomen. So given this muscular action, the basic action of respiration is expansion of the thoracic cavity, expanding the lungs through pleural linkage. The diaphragm moves inferiorly and expands the lungs in the inferior direction. The external intercostals pull backwards on the ribs to stretch the costal cartilages, expanding the rib cage anteriorly and laterally. This expansion creates a negative pressure within the lungs by increasing the space inside the lungs occupied by the air. If it can, air will then flow into the lungs to equalize pressure. Once the thoracic cavity structures are stretched out, their elasticity will try to compress the lungs. That compression would create a positive pressure in the lungs, and again air would flow out of the lungs in order to equalize that pressure. It's possible to have additional lung compression beyond that resting state using accessory muscles of expiration to further compress the rib cage.